Okay, I can't break my record of 8:01, so we're going to go ahead and get going. So, welcome to this beautiful fall morning. It's a great day, a little bit of rain later, and that'll be fine. So I am very honored today to present a Grand Round speaker who is fantastic. This is Dr. Adam Gepner. And he is part of our institution. He's been part of us for a long time. He is a clinical adjunct assistant professor in the Division of Cardiovascular Medicine here in the Department of Medicine. And the title of his Grand Rounds is fantastic. It's More Pills? I'm Too Old for This. Personalizing Hypertension Management for Older Adults. So, I'm going to just tell you a little bit about Dr. Gepner. So he was a medical student here at University of Wisconsin, where he was honored with being inducted into AOA and into the Gold Humanism Society, both great honors. He then stayed with us for his training, where he did his internship and residency. He then did a postgraduate year focusing on atherosclerotic imaging and preventative cardiology, followed by his fellowship in cardiovascular medicine. In 2016, when he graduated, he joined the VA as a staff cardiologist here at the William S. Memorial Veterans Affairs Hospital and is a clinical adjunct professor in the School of Medicine and Public Health in our department as well. So Dr. Gepner's had really an incredible 3 years of his career. Most recently, he has received a Career Development Award from the VA. Congratulations to him to that. He has over 25 articles that are peer-reviewed and over 25 posters and abstracts that he has done in his career. He's involved with teaching and is the cardiovascular course instructor for the medical school curriculum. He is also an EPIC super user, so he teaches people who are on faculty and he teaches fellows and residents. He's received several awards that I want to mention. He has received the Outstanding Educator Award from the Cardiovascular Medicine Fellows, and he's also received an incredible award, which is called the Internal Medicine Faculty Wellness Award, which is presented to faculty members who improve resident wellness and mitigate burnout. I think that's fantastic. In the area of research, he received the Multi-Ethnic Study of Atherosclerosis Young Investigator Award. We are very lucky to have him on faculty, and Dr. Gepner, please come up for Grand Rounds.
How many times have you walked into your clinic, sat down with your patient, looked them in the eye, and said, your uncontrolled hypertension is going to kill you? Well, that's the dirty truth. And your patients deserve the truth. They can handle the truth. Most of you know that heart disease is the #1 killer in the U.S. And public enemy #1, hypertension. In fact, the attributable deaths, not just adverse events, not just morbidity, deaths, are increasing. And in the past 10 years, the attributable deaths due to hypertension have risen from 11% to 38%. We talk about heart attacks, we talk about cancer, we talk about end-stage renal disease, we talk about liver disease, and we put it in the context of how serious it is. Why aren't we doing the same thing with hypertension? I didn't do this for a long time. And this, unfortunately, could be my patient. So here's Mr. F. He could be your patient. He's 79, he's got borderline hypertension, he's got prediabetes, and his 2 older brothers died in their late 70s of MIs. His clinic blood pressure, 144/89. Not too shabby, right? You talk to him a little bit more, turns out he tried amlodipine. Actually, his direct quote that I titled this talk used more expletives than I put in there. But he tried amlodipine, he got lower extremity edema, And here's some of the things that he said. So I'm going to give you just like a little role play of how this clinic visit went. Hey, Mr. F. Just let me get logged in here. Oh, your blood pressure doesn't look too bad. I remember you tried amlodipine. You really didn't like it. We have a lot more things to talk about, so let's just skip your borderline blood pressure, if it is even borderline. And that's something that I really hope we can focus in on today. I'm hoping that we can really talk about what it means to diagnose hypertension in 2019, focusing on older population, and I hope to shed some light on some of the controversy and drama that's out there, and really talk about this in the context of aging. Because it's hard. This is hard. There's no one size fits all. And then hopefully towards the end we can rethink some of our solutions about what we're doing and maybe even challenge some dogma. Ubiquitous. That's hypertension. 45% of U.S. adults. A third of our nation's veterans. Once you reach age 60, the likelihood that you will be diagnosed with hypertension, 2/3. It's a lot of people. And we have been interested in this topic for a long time. This is 1991 when the Shep trial came out. Over 4,000 older patients with hypertension who got randomized to different medical therapies, including diuretics, thiazide-type diuretics, beta blocker, placebo. 1991. Anybody know the results of this trial? Reduced stroke and significant reduction in major adverse cardiac events. Doesn't stop there. The MRC working group, another trial of over 4,000 older adults. Different medical regimen, but same basic premise. Reduced events. 2008, HIVET, the oldest old, I love that, the oldest old. Patients over 80, different medical regimen, same basic message. Randomized clinical trial showing decreased events, particularly stroke. And it keeps going. I guess I should say SPRINT, because that's the most recent one. 2015, SPRINT. Anybody read that one? Yeah. So they actually did a sub-analysis of patients who are over 75. 2,600 patients who were randomized to either intensive blood pressure control or standard of care. And those who had their blood pressure lowered to that 120 millimeters of mercury goal reduced outcomes, improved mortality. Guidelines. Who doesn't love a good guideline? So the AHA and the ACC, which I'm biased, I'll admit it. I didn't put that on my disclosures, but I'm biased. I'm a cardiologist, so I read these probably more than other guideline bodies. Class 1A recommendation for the treatment of hypertension in older persons. And the recommendation is a blood pressure treatment goal of less than 130 millimeters of mercury for non-institutionalized, ambulatory, community-dwelling older adults greater than 65 years of age. I wish they'd made that a little bit more succinct, but what does this mean for our patients? Poor Mr. F. More pills? He hated amlodipine. This is what makes medicine so fun, is that we can debate and talk and acknowledge the fact that we really don't know the right answer all the time. I'm going to put this on a t-shirt. I'm going to take orders after grand rounds. Remember JNC7? Chuck? I know you remember JNC7.
That's actually relatively recently.
JNC7. You know, sometimes I just sit there and think, it was so easy back then. Everybody had the same goal, unless you had diabetes, I suppose, but we won't get into that. There was no definition of older adults. Just treat their blood pressure. Get them down. 140/90. A decade goes by. Here's 3 more guideline bodies between 2003 and 2013, all which have slightly different definitions of older adults and slightly different blood pressure goals. This is what it looked like in the Supreme Court in the late 1700s. That guy in the middle is a clergyman, and they're praying for agreement. And this is what we were doing when JNC 8 was about to drop. Anybody remember when JNC 8 was about to drop? Well, the pendulum swingeth. And now, in 2014, despite all the literature that I showed you suggesting that lowering blood pressure in older adults is beneficial, the pendulum swingeth. This created a lot of hullabaloo in the cardiology and medical community. And so it didn't take very long for more guideline statements to come out. The AHA-ACC guideline that I cited before and the ACP-AFP guidelines came out within like a month of each other. And they basically said very different things. Controversy, debate. And then to make things even more confusing, the European Society of Cardiology came out with another guideline statement that, again, had slightly different recommendations for older adults. Seems like it should be a good talk for a grand rounds, don't you think? For those visual learners, here's the pendulum. So in 1991, Shep enters the picture. JNC7 follows with lower blood pressure goals. HiVet comes in, oldest old, and then we get JNC8 where the pendulum swings. And then Sprint in 2015, followed by still debate. So here's the big thing that a lot of people were talking about with regard to the new goals that came out, was that all of a sudden, way more people, particularly older people, because you remember how prevalent it is, were going to be diagnosed with hypertension. 31.1 million more, according to NHANES data. Mr. F, is he going to need more meds? Well, here's something I don't think a lot of people recognize. And one thing I really, if you're going to remember one thing from this talk, it's that just because somebody's diagnosed with hypertension does not mean they need more medicine. From this data set, only 4.2 million more adults would require pharmacologic therapy. That's still a lot, but it's not 31 million. And that brings us to the cornerstone of hypertension management, which we as clinicians and providers tend to gloss over. Lifestyle. Because it's hard. It's hard to talk to our patients about lifestyle. We don't have a lot of time. Patients want an easy fix. Obesity, diet, substance use like alcohol and cigarettes, exercise. They kind of all go together, don't they? You can't treat obesity without talking about diet and exercise. You can't talk about diet without talking about liquid calories, especially here in Wisconsin. Weight loss. 1 millimeter of mercury per kilogram of weight loss. This is straight out of the guidelines. Evidence-based, even in older adults. Healthy diet. If you're going to lose weight, you got to have a healthy diet, or you should, unless you have some other tricks up your sleeve. The DASH diet, which has been extensively studied to lower blood pressure, which includes low sodium, non-fat dairy products, plenty of fresh fruits and vegetables, avoidance of alcohol, lowers blood pressure by 11 millimeters of mercury. That's more than most medical therapy. You cut out alcohol or cut down for a lot of people, and you still reduce your blood pressure. Any type of exercise, doesn't matter what you're doing, any type of exercise will have a significant impact, positive impact on blood pressure. But we don't talk about it as much as we should. And I think it's hard because older adults are not like younger adults. I remember on my pediatric rotation, they always used to tell me, kids aren't little adults. I wish I had like a nicely packaged way to say that about older adults, but I don't. So they're still just adults. And I suppose you can treat them like adults, but you shouldn't. You should treat them like older adults. Because as you get older, blood vessels become stiffer, and that translates into morbidity, like organ damage, decreased perfusion, renal dysfunction, heart disease, stroke, badness. And older adults are less likely to achieve goals on treatment. When you're 65, the likelihood that you'll be at blood pressure goal, and these are older blood pressure goals, more liberal blood pressure goals, 46%. So it's probably even worse depending on what you're using as your quote-unquote goal. And once you get to 75, only a third of our patients are at goal. And I think it's fair, I think it's fair for us to think about this because, yeah, we have clinical trials, but is that representative of all older adults? No. Those trials enrolled people who may have been healthier, definitely able to participate and consent in a clinical trial. Most of them have exclusionary criteria for institutionalized adults, including people who live in nursing homes and skilled nursing facilities. It's not just us, though. You heard that one? I'm too old to change. Everything hurts. How can I exercise? I've got arthritis. My knees hurt. My back hurts. My food needs salt. Taste buds change over time. There's changes in sensation. Things don't taste the same. I'm not giving up my brandy old fashions. So now we're back to page 130 out of 152 in that guideline statement. And now we're down to a 2A recommendation for older adults greater than 65 years of age with hypertension and a high burden of comorbidity and limited life expectancy. We need to use clinical judgment, patient preference, team-based approach to assess the risks and benefits to decide if it's reasonable to start blood pressure lowering antihypertensive drugs. But here's the good news. You're an expert. And I hope your expertise grows even further after this talk. But your patient's also an expert. Our patients know themselves better than anyone else. They may not be an expert in medicine, but they are an expert in themselves, for sure. And sometimes we need help. I really think that it's important to talk to our patients about risk and all the different types of risks there are, but particularly the risks related to hypertension. And again, this is when it becomes tricky, because age is risk to the fourth power when you think about the pooled cohorts and calculating atherosclerotic cardiovascular disease risk. Anyone want to hazard a guess? Mr. F. 30%. Okay, so that's a good guess. Some of you might be saying, well, Dr. Gepner, you didn't present us with enough data to calculate his true risk over 10 years. And that's true, I didn't, purposely. Because what I want you to remember is age to the fourth power. Once you hit 65 years old, age is such a powerful predictor of risk that benchmark cutoff that the guideline uses for starting treatment, greater than 10%, or a history of CVD, 88%. Mr. F, he's 79. Once you hit 75 years old, the risk is 100%. Age to the fourth power. It's huge. But that's what makes this really hard, because all of our older patients are at high risk. But even though they're at high risk, if they're community-dwelling, ambulatory adults who fall into the catchment of those people who are enrolled in the trials, no trial has ever showed significant harm due to more aggressive blood pressure lowering. But it does reduce morbidity and mortality, even in frail patients. Half the patients in that sprint trial that I showed you, half of those 2,600 patients were frail. No changes in orthostatic hypotension, reduced rates of AKI, reduced rates of dementia. But we see these people in our clinics, right? They come in. You started that medicine, and I feel terrible. It happens. These aren't all easy to tolerate. And I don't know that our studies do the best job of really figuring out and really deciphering quality of life metrics. So it's a balancing act, and we're struggling. I'm struggling. This is hard because these patients are vulnerable. They take a lot of medicines. They're frail. They have comorbidities. They may have cognitive impairment. Their life expectancy is variable. The reason why age to the fourth power is because lots of things happen as you get older, not just heart disease and stroke. What about the costs? And of course, we got to take into account our patients' preferences because they're the expert. But we still need help sometimes. And so when you have this patient in your clinic and you're trying to decide, what should I do? How should I help this patient? We've maxed out lifestyle, but he still needs a medication. So we turn to the guidelines, and we get crickets. The guidelines make no recommendation about which medicine to start, because one size really fits no one when it comes to hypertension. Talk to your patients. Take a few extra moments. Don't just glance at that blood pressure and say, pretty good. Talk to your patients. Delve into it. What are they doing? Have they really maxed out their lifestyle? Could there be a reversible cause? Could there be something that we're missing? Is this truly essential hypertension, or is it something else? Make sure they are cutting down on those brandy old fashions. Talk to them. It's not just adding table salt to your food. It's about the salt that's in processed food. And this has actually been studied. It's not the added salt. It doesn't help, but it doesn't matter if you're adding salt to your potato chips. They've already got enough salt. So don't just talk about that, because I think that's a misconception that a lot of patients have. Nothing tastes good unless they add salt. But what about all that salt that's built in? And unfortunately, that's our culture, that's our society. And we'll work on change in that realm, but maybe that's another grand round. Sometimes you have to start over. Go through their med list one by one. How many people have encountered a patient who have been on an antihypertensive regimen for the past 20 years? Yeah, happens all the time. Dr. Stone started those medicines.
After 10 years of therapy.
And we're really quick to say, let's not change things, let's not shake the wagon, whatever the saying is. So sometimes you just got to start over. Start from scratch. We have a lot of data. Here's another thing we don't do. We don't set realistic expectations with our patients. Mr. F, you've really done a great job. I commend you. You're down to 1 brandy old fashioned a week. You're walking almost every day. You cut out that processed turkey. I'm really proud of you. But it looks like you're still going to need some medicines. This is going to take time. We're going to have to do some trial and error. We're not smart enough at this point to know exactly what medicine you're going to need and how much. Anybody ever said that to their patient? Good. If you have, you should be. Because I think the most frustrating things for patients is we're starting these medicines and then they're not seeing results or they're not feeling good. And know the data and the gaps. Know where your patient falls in that spectrum. Because yes, we do have a lot of data, but it can't be applied to everyone in a blanket form. And is there evidence of end organ damage? Do they have renal dysfunction? Do they have cardiovascular disease? Have they had strokes? And if they have, you may want to be more aggressive. But you have to put it in context because we don't want to start medicines, especially in older patients who may have limited life expectancy, that's going to adversely affect their quality of life. It's a give and take. And we need to take a team-based approach and use all of our healthcare resources, starting with Mr. F and his family, and sometimes his friends, nurses, APPs, physicians, including specialists, clinical pharmacists, psychologists, and even the community interventions. So you have to know what's available to you and to your patients. So these should be our goals: to control their blood pressure, reduce events, minimize side effects, so that we can all live full, happy lives. It's not easy. And sometimes when things aren't easy, we start having to think about them more critically. And that's what I've spent a lot of time doing. And one of the areas that I'm really interested in, and I hope to share with you, is about how arterial stiffness plays into this. Arteries are a tube, if you put that in the simplest context. And blood pressure and arterial stiffness are tightly linked. So if you look up at this diagram and you see arterial stiffness in red there, the biggest predictor of worsening arterial stiffness is age. Because with age comes injury to the endothelium, that inner lining of the artery. And as that happens, things get stretched and displaced, and you have damage to the elastin, and collagen gets deposited into the artery walls. And that actually leads to events and morbidity and mortality. But it feeds back on itself. Because as your blood pressure gets stiffer, your blood pressure goes up. Or as your blood vessels get stiffer, your blood pressure goes up. And then it feeds back because you're causing more injury, more collagen deposition, more fragmentation of elastin. So just in terms of a little bit of background, this person's using a tonometer. It's a pressure wave, a way to measure pressure waves in any artery. And this can be done in a regional fashion where you can either do it from the carotid artery in the neck to the radial artery, like it's being showed here, or to the femoral artery. And that's how we do it. And basically, if you look at the time it takes for your waveform to be propagated from the common carotid artery to the common femoral artery, and you know the time and the distance between those 2 points, you can calculate a pulse wave velocity. And you can imagine as that tube, that artery gets stiffer, blood propagates faster. So higher pulse wave velocity, stiffer arteries. We can also directly image arteries with ultrasound. So this is a M-mode ultrasound of the aorta. And look at changes between systole and diastole. And the more change there is and in relationship to the pulse pressure, can tell us how elastic and distensible these arteries are. So here's a lot of math that looks at the distensibility coefficient, DC, and Young's elastic modulus. But I don't really expect you to remember that. So again, I'm more of a visual learner. And here's what the artery looks like in systole. So it expands as blood comes through, and then when your artery relaxes in diastole, it gets smaller, and we take the difference between those two measurements and divide by the pulse pressure, the change in pulse pressure, and a constant at diastole. And that's how we get distensibility coefficient. Young's modulus is very similar. It actually has distensibility coefficient in the denominator, so it's an inverse relationship, and it takes into account that H term, which is wall thickness. So how that change in distensibility is felt by the wall is another way to think of it. But the bottom line is lower distensibility coefficient, higher Young's modulus, faster pulse wave velocity is equal to stiffer arteries. So does stiffness matter? Well, I think it does, but I hope I can convince you of that. It increases with aging. It's associated with cardiovascular disease risk factors. It's tightly linked with high blood pressure, and particularly poor blood pressure control, and especially pulse wave velocity contributes to atherosclerosis and major adverse cardiovascular events. It matters. So let's look at some data. And again, this is all being done at rest. The patient's just sitting there, relaxing. We looked at this in a large population-based data set called MESA, the multi-ethnic study of atherosclerosis, which followed patients at all ages over time. And we did this study, we had about 10 years of follow-up. And we had ultrasound images of the neck in about 2,600 patients. And what we found was age matters. That line that's kind of going off the charts at the top of the graph shows Young's elastic modulus, so you're stiffening over time. And those patients that are 75 to 84 years old stiffen way faster than any other age demographic. We also looked at the use of blood pressure lowering medications and found that the use of antihypertensive therapy slowed progression in all age groups. We then looked at a subset of these patients, all who had high blood pressure, only who had high blood pressure. And what we found was that if you were treated and uncontrolled at all visits, which you can see in that black line, you had a significantly greater increase in your Young's elastic modulus compared to those who were treated and controlled at all visits, independent of age. I love this slide. What do you do? But I think the point of me putting this up here is that blood pressure, I think I can convince you, is dynamic. Imagine you're giving grand rounds. Your blood pressure is probably higher than if you're sitting in the audience. If you're on fire, I hope your blood pressure is high so you can stop, drop, and roll. If you're being chased by a bear, I hope your blood pressure is higher so you can run. That's adrenaline. That's physiology. But why are we measuring resting blood pressure if it's supposed to change? Same with stiffness. Why are we just measuring resting stiffness if they're so linked yet so dynamic? So maybe these resting metrics are just a fool's gold standard, silver standard, bronze standard. The one thing they have going for them is they're definitely easier to measure, but just something to think about. So we came up with an idea that if these things change with what we're doing, and we can measure that, maybe we can use it to determine who should be more aggressively treated for their blood pressure and who shouldn't. So we came up with this concept of arterial reserve. And it's basically the blood vessel's ability to adapt to changes in blood flow and changes in pressure. More arterial reserve, more ability to adapt to things like stress, exercise, being chased by a bear, giving grand rounds, and medications. So if you put someone on a treadmill and have them run at their maximum capacity, you're going to get changes, physiologic changes that are normal. Their heart rate goes up, their stroke volume goes up, their cardiac output goes up, and you better believe their blood pressure goes up. But what happens when they stop exercising? They should come back to normal. And they should come back to normal relatively rapidly. What about medicines? If you give somebody sublingual nitroglycerin, you drop their afterload, drop their preload, drop their blood pressure. But once the effects of the medication wear off, your body is smart. Physiology is cool. You come back to normal. So this is the concept of arterial reserve. Time is on the x-axis, and arterial stiffness measures are on the y-axis. And you can see that in a normal patient, participant with healthy blood vessels, they have this rapid rise with exercise, and then it rapidly recovers, maybe even falling below baseline. Whereas an atypical response to stress might look something like this, where you have a slow rise and a slow decline and less arterial reserve. And that's what we hope to measure and see if it can be predictive of blood pressure control. Here's how we do it. One way that we do it, we look at the carotid artery. This is an ultrasound image of the carotid artery. We make a region of interest, which is that green square, and then using a semi-automated border detection program, we can follow the motion of the walls throughout the cardiac cycle and calculate some of these parameters. Simultaneously, we're getting pulse wave velocities. And so this is what it looked like in our pilot study, where we looked at 17 older subjects with sleep apnea. And I'll have you focus your attention to the graph on the right, which mirrors what we were seeing in those curves. But you can see there's all different varieties of people with changes in their peak, that arterial reserve. But most people come back to baseline by about 10 minutes. And this was associated with blood pressure control at baseline. So our plan is to enroll veterans who are over age 60 years old, most of whom have varying degrees of blood pressure control, but including 30 non-hypertensive controls. And we're going to assess a lot of parameters that look at different characteristics of the artery, including pulse wave velocity, distensibility, and Young's elastic modulus with stress. We're also going to look at blood pressure too. So we'll have that data as well. And we have a 2-day protocol that we are doing in a cross-sectional fashion, and we're hoping that this is going to be predictive, like in our pilot study, of blood pressure control at baseline. So imagine, here's Mr. F. He presents to clinic. He's got elevated blood pressure. Sound familiar? So you have a nice discussion, and you tell him, cut out the brandy old fashions, exercise more, watch out for processed salt, and go home and get more data. But despite optimizing lifestyle, he still has high blood pressures at home. There's me. Should have gotten a better picture. But I'm concerned. Mr. F, he's 79 years old. He's vulnerable. He hates medicines. I don't know how aggressive to be. Oh, maybe I'll look at the guidelines. Oh wait, that was no help. What if I could order a test that looked at the dynamic function of this patient's arteries and determine how much arterial reserve he has, and then use that to guide how aggressive I am with blood pressure management? That sounds pretty good to me. Takes a little bit of the guesswork out of it. We don't have a test. We can't just get a cheek swab, throw it in the spinner, and have it spit out the answer of how much and which medicines. Not yet, at least. I hope that day comes, but we're not there yet. So I think we're still in the realm where we really have to consider using physiology to guide our therapy. But that's our goal. We're not there yet. We're hoping to get more information. And hopefully someday this will translate into the ability to treat our patients in a better way, specific to how their arteries respond to stress. I know, you guys are like kind of let down because you're really hoping to figure out a way to help your patients. Well, never fear, because I think you already have a lot of the tools that you need. You may have just not recognized that you have those tools. And having these risks and benefit discussions with your patients and putting them in context is the first step. Everybody knows start low, go slow, right? The old adage in older adults. Well, don't forget, start over. It's okay to start over. It's okay to start from scratch. Sometimes that's more beneficial than trying to tweak things and make changes. The cornerstone. Don't forget the cornerstone. Expectations. Set expectations. It's so important for your patients to know what to expect. We're going to start Lisinopril, 2.5 milligrams every day. Here are some of the side effects you might expect. You might feel lightheaded or dizzy. It can affect your kidneys. It can affect your electrolytes. So we're going to monitor those. Make sure you're checking your blood pressure every day at variable times so we can see how it's affecting you. Because we're not sure if that's the right dose for you. You might need more. You might need a different medicine. But if we just hand a prescription over, our patients don't know that. Even though the guidelines recommend that if their blood pressure is over 160, you can start with 2 medicines, I recommend in older patients, start with 1. Align it with their comorbidities, and go slow. And you can be smart about this. So when we think about those trials and we think about the guidelines, there's evidence to suggest that the primary agents listed here, like thiazide-type diuretics, ACE inhibitors, ARBs, calcium channel blockers, have the most data that impacts cardiovascular events. So start with those, all things created equal. And then, depending on how they respond or different comorbidities, sometimes we have to add loop diuretics or aldosterone antagonists like spironolactone. And then the medicines with the least amount of evidence are those like the beta blockers, alpha blockers, and direct vasodilators. But a lot of older adults have comorbid conditions. So this is where you got to get smart. This is where you have to think about your patient as a patient. They're not just a number. They're not just 146 over 89. This is Mr. F. And we got to think about his comorbid conditions. Do they have angina? I'm sure all of you can look at this list and pick a medicine from here that may actually help them with their angina and lower their blood pressure. Calcium channel blockers, even those beta blockers. Heart failure, same thing. We see these every day in my clinic. And you can be smart about tailoring their medications to their disease. Diabetes, make sure they're on an ACE or an ARB to protect their kidneys. What if they have kidney disease? Same thing, depending on what type of kidney disease and what it's from. Arrhythmias, think about it. Just have to put it in context. Or if they have tremor, maybe they would benefit from a non-selective beta blocker. And also think about some of the other symptoms that they're having. What other troubles are going on in their life? Are they up every night, going to the bathroom? Probably don't want to start a diuretic in those patients. Or maybe consider starting a different medication instead. Are they orthostatic? Do they have frequent falls? Maybe those are the people that you want to allow to run a little bit higher so you're not predisposing them to significant adverse events. And then reinforce adherence. We can't get good data unless patients are actually taking the medicines we're prescribing. So make sure they're actually taking it. Get them a blood pressure cuff to take home. Here at the VA, if you need a blood pressure cuff, you get one. It's free. You go home and you take your blood pressure. Show them how to use it. Empower them. Empower your patients. We're in this together. This is the fight for your life. You don't want to fight one-handed. And then maybe consider crossing these off their list if they're only being used to treat hypertension. Beta blockers, especially in the elderly, not a lot of convincing evidence that it's going to improve outcomes, and they don't work all that well for blood pressure. Alpha blocker, unless they have BPH, usefulness is pretty limited, and actually studies have shown that these increase badness. Same with nonspecific vasodilators. These should be your 4th and 5th line agent. He looks so sad, doesn't he? Well, what did we do with Mr. F? We know his risk is high. We sent him home. We had him cut out brandy old fashions. We had him increase his exercise. Maxed out his lifestyle. He doesn't have a lot of comorbid conditions, but we know he hates amlodipine because it gave him lower extremity edema. So we started him on a low-dose ACE inhibitor because he's got prediabetes, smart prescribing, right? And we followed up. And it took a little extra time. But I think it was worth it. We don't have any new metrics yet, but I hope they're coming because we need something to help us. And I think remembering that blood pressure is physiologic. So when your patient comes in to the clinic and they sit down in the chair, you take their blood pressure, and it's high, be careful, right? What if they had to go to the bathroom? What if they had to pee? What if they come from a small town and they had to drive through Madison traffic that was really stressful to them? What if they just had a cigarette in the parking lot? What if they're super stressed because you're talking about the fact that they may have cancer, or they may have heart disease, or they may have liver disease? This is stressful. It's not easy going to the doctor. It's stressful. So make sure that you're giving them time to relax. Make sure they've gone to the bathroom. Make sure you have an appropriate cuff that actually fits them. Take the time to get good data. Because if you don't have good data, you're not going to be able to treat your patient. That's in the guidelines, by the way. Get good data. And maybe someday we'll have some new metrics. So poor old Mr. F, we went back in time. We were able to counsel him, get him on a little ACE inhibitor, and lo and behold, he's actually doing pretty well today. But I'm glad I told him that his high blood pressure could kill him. And I'm glad I told him that he was an expert in himself and that we were going to work together to get his blood pressure under control. Because he was on board. Look at those medicines over there. He's up to 3 pills. And now he can live his best life and do the things that he wants to do, the things that are important to him. And hopefully your patients can do the things that are important to them. So be resourceful. There's lots of resources here at the VA if you're a VA provider. Help people get enrolled in these programs so that they can help themselves. Empower your patients. At UW, we have our advanced hypertension program through our preventative cardiology group. Nutrition counseling, exercise programs. These are all resources that are available on our website. So that's pretty much all I have, except for the fact that I'm really grateful to a lot of people, including all of you. Thank you for coming. Thank you to the outstanding leadership I have in my division and in the department. And thank you to the VA Research Office for countless hours of tireless help submitting and resubmitting my grants. My mentorship team, some of who couldn't be here today, Dr. Carlson, Dr. Chesler, Dr. Cook, and Dr. Astana. You guys are the best. And my lab team, Dr. Stein's lab in the AARP, Dr. Korkars, Kristen Hansen, Carol Mitchell. Thank you guys for helping me grow up in this field. And you can help me. So if you have VA patients who are over 60 years old, I'm looking for people with essential hypertension and healthy controls who can walk on a treadmill, who don't have cardiovascular disease or kidney disease. Send them my way, or come talk to me after. And I would be honored to take your questions.
Does the vascular physiology correlate with those that have adverse symptoms like postprandial symptoms for people on blood pressure meds?
I don't know. How about we find out?
Okay.
Oh, sorry. Does arterial stiffness measures correspond with adverse symptoms, particularly postprandial is what was brought up? We don't know. This has not been studied. Everybody looks at this under resting conditions primarily. And particularly there's been some studies in younger adults, but nothing in older adults. But that we are doing a lot of surveys in our study to try and get to the bottom of not just quality of life type symptoms and adverse effects, but also correlating that with adherence and how often they're taking their blood pressure medicines.
In the back.
Adam, thanks for the talk. It was wonderful and quite uplifting. So measuring, I think resting measures are measured because they're easy, right? And it's a prevalent disease, and so it's going to take a lot of resources to get measures that are not at rest, I think. And it's going to be a beautiful study to help prove this arterial research question is how we can tailor our therapies based on the common. Study also looking at predictors of that so that we can go backwards and get that G squat, or maybe it's using environmental exposures and family history and DNA. Be able to do it at rest, but predict that dynamic.
Thanks, Matt. The question is, resting measures are done because they're easy to acquire? And are we going to look at associations between resting measures and dynamic measures in our study? And the answer is yes. The other point that I will make is that this would not be necessarily a substitute for resting blood pressure medicines. This would be a targeted test to individuals who may be at risk. So this wouldn't be blanket for everyone. This would be, you're not responding, or you've had side effects in the past, or you've had difficult to treat blood pressure in the past. This person should get this test, not everyone. But thanks for the question. Does that answer it?
Yeah.
Spoke about the trials that showed that more aggressive blood pressure lowering has positive outcomes and how the guidelines shifted over time. There were some large trials during that period that showed that being too aggressive with blood pressure actually harmed people. Can you speak to that discrepancy?
Sure. The question relates to, is asking how there are some trials that have shown harm with too aggressive blood pressure control, and how do we kind of align those with the other trials that I talked about. And what I'll say to that is a lot of those trials were smaller, and I think one thing that is important to point out is it matters who you're including. So again, the patients that may have been included in those larger trials may not have been representative of the entire older population. And I acknowledge that as something that we need to think about when we're prescribing for our patients. And that's why it's so tricky, is because there are patients who show up and have adverse effects, who don't feel good on these medicines. So they're out there, and whether the big trials show it or not, they come to our clinics. So you're absolutely right. We have to be cognizant of that, and that's why I really want to stress Make sure you're doing everything you can that's non-pharmacologic before you start bombarding people with medications, which may make them feel worse. Because there's a lot you can do if you can get somebody on board with lifestyle.
Other questions, come up to the front. Thank you very much.
Thank you.